Welcome to Advanced Practice, where we brew together excellence in mental health practice. In the previous episode, we explored lithium, which combines anti-manic efficacy, maintenance benefit, and anti-suicidal potential. But lithium was never the complete answer. Some patients didn't respond adequately. Others could not tolerate the side effects, monitoring requirements, or long-term medical concerns. And not all mania look the same. Some patients present with classic euphoric mania like elevated mood, grandiosity, decreased need for sleep, hyperactivity, and impulsive behavior. Others present with irritability, agitation, dysphoria, aggression, or rapidly fluctuating mood states. Some cycle repeatedly between mood episodes within the year. Others develop mixed features where depressive and manic symptoms coexist simultaneously. And this growing complexity created space for another major class of medications to enter psychiatry: anticonvulsants. Among them, Valproate became one of the most influential. Originally developed as an anticonvulsant for epilepsy, Valproate eventually demonstrated strong efficacy in acute mania, particularly in patients with severe agitation, mixed states, irritability, and rapid cycling presentations. For many clinicians, Valproate appeared easier to use than lithium. There was no narrow therapeutic window in the same sense. Toxicity concerns felt more manageable. Monitoring still mattered, but the medication was often perceived as more forgiving in routine practice. And more importantly, Valproate worked well in highly activated patients. This became especially relevant because bipolar disorder was increasingly recognized as more than episodic euphoria. Many patients presenting in real-world clinical settings had complex symptom clusters involving insomnia, impulsivity, anxiety, dysphoria, substance use, aggression, or emotional lability. Valproate mechanisms are broad and still not completely understood, but Valproate appears to enhance GABA activity, modulate voltage-gated ion channels, and influence excitatory neurotransmission. Clinically, the medication often produces a calming and stabilizing effect on behavioral intensity and mood dysregulation. For acute mania, dosing frequently begins around 500 to 1000 milligrams daily, with gradual titration upward depending on symptom severity, serum levels, and tolerability. Many patients ultimately require doses between 1000 and 2000 milligrams per day, though individualized treatment remains essential. Therapeutic serum levels commonly target approximately 50 to 125 micrograms per milliliter in bipolar treatments. But as Valproate became more widely used, psychiatry also began confronting its limitations. Weight gain became a major issue. Sedation, tremor, gastrointestinal effects, and cognitive slowing were common complaints. Over time, clinicians also became increasingly aware of metabolic concerns, hepatic risks, thrombocytopenia, and endocrine effects. Then came one of the most important turning points in modern psychopharmacology: the growing awareness of teratogenicity. Valproate exposure during pregnancy became strongly associated with neural tube defects and developmental risks, including cognitive and neurodevelopmental complications in exposed children. This dramatically changed how clinicians approach prescribing, particularly for women of reproductive age. And this is where bipolar treatment became ethically and clinically complicated, because Valproate is often highly effective. Many experienced clinicians will tell you that some patients with severe mania, mixed states, impulsive aggression, or rapid cycling respond extraordinarily well to Valproate. In some cases, it may stabilize patients who failed multiple alternatives. But effectiveness alone is not the only consideration in modern psychiatry. Clinicians now must weigh symptom control against metabolic burden, reproductive safety, long-term health risks, cognition, adherence, and quality of life. That's it for today. Thank you for joining us on Advanced Practice. In the next episode, we will move into another major chapter in bipolar treatment, lamotrigine. See you soon. Bye.